Do you want to meet our patient? Let me tell you about Mr. Ahmed. He is a 65-year-old man who came to our clinic complaining of shortness of breath and exertion, swelling in his ankle, feeling more tired than usual over the past 3 months. Past medical history includes hypertension and he is a former smoker. Now, let's examine Mr. Ahmed systematically to figure out what's going on with his cardiovascular system. Before we even touch the patient, we observe as Mr. Ahmed walks into the room, what do we notice? Is he breathless at rest or just after walking? For Mr. Ahmed seems slightly short of breath and after walking from the waiting room. And for his general comfort, does he look distressed? Can he speak 4 sentences? Is he overweight? Because extra weight means the heart has to work harder. Is he really thin and wasted looking? That cachexia thing could mean his heart's been failing for a while. Does he look unusually tall and thin with long fingers? Could be Marfan syndrome, which affects the heart too. Is he sweating? Could indicate a heart failure or acute coronary syndrome. Finally, we check skin temperature and color. In Mr. Ahmed's case, is slightly overweight and appears comfortable at rest but was breathless walking in. This already tells us something about his exercise tolerance. Let's start with Mr. Ahmed's hands. You would be surprised how much information they can give us. First, take a close look at his nail. Do you notice any increased curvature? That could indicate clubbing, a classic sign seen in conditions like cyanotic congenital heart disease, infective endocarditis, or a chronic lung disease. Next, check for tiny dark lines running under the nail. They look like splinters. These are called splinter hemorrhages. They might suggest infective endocarditis. But remember, trauma is a much common cause, so don't jump to conclusion too much quickly. Now, observe the color of the nail and fingers. If you see a blue discoloration, that could mean a pure oxygenation, often due to the serious heart or lung disease. Mr. Ahmed's hands show no clubbing, no splinter hemorrhages, and they are pink and well perfused, which is a good sign and makes congenital heart disease or endocarditis less likely. Now, let's check Mr. Ahmed's radial pulse at the wrist. We use our index and middle fingers. We count the pulse rate, which is normally 60 to 100 beats per minute. Mr. Ahmed's rate is 88 beats per minute, within the normal range. At the same time, we check the rhythm. If the beats are irregular and equal in strength, it indicates sinus rhythm. If the beats are irregular and vary in strength, it indicates atrial fibrillation. Mr. Ahmed's pulse is irregular, which is a classic for atrial fibrillation, a common arrhythmia that increases stroke risk and can cause a heart failure. Then we check Mr. Ahmed's blood pressure. He is seated with his arm supported at the heart level using the correct cuff size. His reading is 152 over 95 mm of mercury. That's elevated. And with his atrial fibrillation, it increases his cardiovascular risk. Important clinical pearl for blood pressure: always check both arms if you suspect vascular disease. A difference over 15 mm of mercury may suggest arterial stenosis. While the radial pulse tells us rate and rhythm, the carotid pulse tells us about the pulse character, reflecting what the heart is doing. Now for the patient's carotid pulse, it feels normal, brisk, upstroke, good volume. But what if it was bounding pulse? A bounding pulse feels large, forceful, and high amplitude, often described as like a water hammer because it hits harder and drops quickly. This happens when the heart is pumping a large stroke volume with each beat. The main cause you need to think about is aortic regurgitation, blood leaking back through the aortic valve. What if the carotid pulse was slow rising pulse? A slow rising pulse feel weak, delayed and plateau-like, described as like pushing through resistance, because the upstroke is gradual and sluggish. This is the classic sign of severe aortic stenosis, where the narrowed aortic valve obstructs blood flow and makes hard to pump blood out. Mr. Ahmed's normal character makes significant valve disease unlikely at this point. Now, let's check the right heart from the jugular venous pulse. The position of Mr. Ahmed at 45 degrees. Head turned slightly left, so we can along the sternocleidomastoid muscle for pulsation. Unlike the carotid, you can feel it. It has 2 beats per cardiac cycle. It moves with breathing and position. Let's calculate the jugular venous pressure. We measure the vertical distance from the sternal angle up to the top of the jugular venous pulsation. Normally it is less than 3-4 cm above the sternal angle, but for Mr. Ahmed the GVP is more than 4, so it is elevated. This just increased right atrial pressure, right heart failure, fluid overload. Next, we press on his abdomen and watch the neck veins, which is the hepatojugular reflex test. In the Mr. Ahmed, the GVP rises and stays elevated, so positive test. This confirms right heart dysfunction. Now, let's work our way down to complete the peripheral vascular exam. We palpate both femoral arteries in the groin. Mr. Ahmed's are present and equal bilaterally. Then we feel the radial and femoral pulses simultaneously. They should be synchronous. Any delay suggests aortic coarctation, which is the radial femoral delay test. For Mr. Ahmed, it is negative. And now, let's check the lower leg pulses systematically. Popliteal present but difficult to feel, it's common thing. Posterior tibial and dorsalis pedis present bilaterally, so all pulses are present, good peripheral circulation. Now, we press firmly over the tibial bone for 5 seconds. In Mr. Ahmed, there are significant pitting edema bilaterally up to the mild cuff. What causes this? Right heart failure, most likely in Mr. Ahmed, but it could be also venous insufficiency, kidney disease, liver disease. Combined with elevated GVP, this confirms right side heart failure. Alright, that's it for the part 1. We went through 7 key examination points using Mr. Ahmed's case. If you have any question, drop them in the comments. This is just part 1 of the cardiovascular examination. In part 2, we will get into more details about heart sounds and murmurs. Hit that subscribe button so you can catch part 2 and all other clinical stuff coming up. Thank you for watching. See you next time.